Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, A European Collaborative Study of Natural History, Outcomes and Validation of Prognostic and Response Criteria in IgM-Related AL Amyloidosis, by Sajitha Sachithanantham et al. My name is Peter Millay, and I'm an Associate Professor at the Princess Alexandra Hospital and University of Queensland in Brisbane, Australia. My oncologic specialty is amyloidosis and the plasma cell dyscrasias. Amyloidosis refers to diseases caused by the extracellular deposition of insoluble protein fibrils which progressively accumulate to disrupt organ structure and function. The most common type of amyloidosis is light chain or AL amyloidosis, where the causative protein is a monoclonal immunoglobulin light chain. AL amyloidosis is a rare disease with an approximate incidence of 10 cases per million. In the majority of cases, an underlying plasma cell disorder is responsible for the production of the monoclonal light chain, but in approximately 5% of cases, there is an IgM monoclonal protein produced by an often subtle lymphoproliferative disorder. It is to this disorder of IgM-related AL amyloidosis that the authors of the attached article turn their attention. On encountering a new case of AL amyloidosis associated with an IgM monoclonal protein, clinicians are confronted with a number of uncertainties. Is the disease behaviour similar to the more common cases of AL amyloidosis which don't have an IgM monoclonal protein? Do traditional prognostic staging systems apply? Can treatment be monitored by the current consensus criteria, which are primarily based on serum-free light chain responses rather than monoclonal protein responses? And of course, what is the best treatment strategy given that current AL amyloidosis therapies target an underlying plasma cell disorder rather than a lymphoproliferative one? The authors are to be commended for undertaking this large, international collaborative study of 250 patients to establish the answers to some of these questions, and thus provide a platform for the evaluation of future management strategies. Their findings highlight a number of important points which are worthy of discussing. Firstly, IgM-related AL amyloidosis is a distinct entity. Compared to patients with non-IgM AL amyloidosis, patients with IgM-related amyloidosis have less cardiac involvement, but more lymph node and soft tissue involvement. It is possible that these latter features relate to the presence of peritumoral amyloidosis associated with lymphoma at those sites. The monoclonal light chain disease burden is less than the underlying disease. The monoclonal light chain disease burden is less, and the underlying disease is typically lymphomatous rather than a plasma cell disorder. This is most commonly, but not always, lymphoplasmacytic lymphoma. Future research to identify the diagnostic utility of molecular markers such as the MYD88 mutation will be important. Given that decisions about therapy rely on accurate identification of the underlying disease that is producing the amyloidogenic protein, it is of critical importance for hematopathologists to make an accurate diagnosis as possible. Secondly, a novel prognostic staging system is proposed. In addition to advanced age and higher Mayo cardiac stage, the authors identified two novel prognostic factors that predicted worse overall survival in multivariate analysis. These were the presence of liver involvement and the presence of neuropathy, including both peripheral and autonomic nerve involvement. The authors then constructed a new staging system, unique to patients with IgM-related AL amyloidosis, which was highly predictive of overall survival. The following four factors were assigned a score of 1. NT-proBNP greater than or equal to 332 nanograms per litre, either troponin T greater than or equal to 0.035 micrograms per litre, or troponin I greater than or equal to 0.1 micrograms per litre, liver involvement measured by a liver span of more than 15 centimetres in the absence of heart failure, or alkaline phosphatase more than 1.5 times the upper limit of normal, and the presence of peripheral or autonomic nerve involvement. Patients with none, one, or more than one factor had median survivals of 90, 33, and 16 months respectively. This new staging system will need to be confirmed by others, but will provide useful prognostic information for patients and will allow comparison of results across various retrospective studies in this rare disorder. Thirdly, monitoring response to therapy requires assessment of the current consensus free light chain-based AL amyloidosis response criteria, as well as assessment of the monoclonal protein response. Only 60% of patients have a serum free light chain level suitable for monitoring response. That is, the difference between the involved and non-involved free light chains being greater than 50 milligrams per litre. In contrast, the majority of patients have a measurable IgM monoclonal protein. Hematological response predicted overall survival, whether measured by the consensus free light chain-based criteria used in non-IgM AL amyloidosis, or whether measured by a 50% reduction in the IgM monoclonal protein. The best overall survival was seen in those with the deepest responses, that is, in those achieving a very good partial response or a complete response. It would seem prudent, therefore, in cases of IgM-related AL amyloidosis, to use both serum-free light chains and the intact IgM monoclonal protein to monitor response to treatment. Fourthly, it is disappointing that deep hematological responses to therapy are uncommon, with only 14% of patients achieving a very good partial response or better. This translated to a low likelihood of improvement in affected organ function and worse overall survival compared to patients with non-IgM AL amyloidosis. Unfortunately, in this retrospective report, the number of patients receiving individual treatments was too small to allow any meaningful comparison of treatment efficacy. It seems intuitive, however, that therapy targeting the specific underlying lymphoproliferative disease to provide the deepest hematological responses will have the best outcome. To this end, future research must focus on optimizing current chemoimmunotherapeutic and novel agent approaches with the aim of achieving deep responses with manageable toxicity. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.